Kari Stephens. I'm a faculty member in Psychiatry and Behavioral Sciences, and I have an adjunct appointment in Biomedical Informatics and Medical Education. And I direct this project called Dataquest for the ITHS. My goal here today really is to give you, as Shunya said, a story about where does this project come from, where are we now, where are we heading, and give you some sort of technical layout of what that looks like just from the informatics side. So to begin, really this was a pilot project that was defined way back when the ITHS very first started, and it was targeting trying to create electronic data sharing across practices and community partners in the WWAMI region. And there really were two directions we were taking that in via the old court core. And one was through the WWAMI region, looking really through family medicine and the work they were doing there to build a network of practices for research. And then the other direction was working with the American Indian and Alaska Native research network building efforts. So we've had these sort of two realms of network building, but the idea way back when was to take existing data sharing architectures like the VDW Group Health way back then in 2006 and try to apply that out in the community. So that's where we started. What we came to, and we published a couple of papers on this, was a data sharing architecture that was federated. And where you can see in this diagram, it's not meant to be super complicated, but you've got on this big left circle the actual electronic medical record system of the practice site itself. So some rural-based clinic, potentially in some city around in the WWAMI region, has an electronic health record system within their practice. We were building a way to pull data out of that system in a semantically aligned fashion that was going to live behind the firewall in that place at multiple of these sites, and really for the purposes of research. So sounded really simple at the time. We thought, okay, how hard could this be? And learned over several years that it became quite complicated. This was not meant for you to be able to read the intricacies of it, but for those of you who are familiar with software development, Bohm did this model of spiral model development many years ago that's really useful and was really useful for our team. Nick Anderson and I really applied this actually in both of our data sharing development efforts to iterate across 4 different dimensions, and was really starting with partnerships and building partnerships and collaborations in that top right quadrant, and then moving down towards defining system requirements that then drove the technical architecture in that bottom left quadrant, and then moving up to promotion and evaluation. And we have been cycling through this iteration for the last, Laura May's here, at least since I've been here in 2008, so for quite a few years. So let me orient you a little bit to these 2 networks that we work with. The first is the WPRN, which is the WWAMI Region Practice and Research Network. And what we have going with Dataquest is data linkages across 5 pilot clinics that the ITHS has funded working with us, and you can see where those are located geographically. So we've got a couple in Idaho, and then the rest are right now in Washington State. And we've also, just to mention, expanded connections to some other partners that we have in Washington State, as well as nationally with a group that we work with called the Dartnet Institute, and I'll talk a little bit more about that. Then we have another network called the Native American Clinical Research Network that Deidre Buchwald's group is spearheading, and we have 2 pilot clinics that are data connected within that network, or it's sort of in progress getting connected at this point, with actual expansions already planned with a couple of other sites once we can move forward. And I really can't emphasize just how long it takes and how hard it is to really build the partnerships. The technical end is really, really easy, but getting all the governance in place and people's buy-in is pretty tough, and those relationships built. So right now in our data sharing network within Dataquest, we have about approximately 103,000 patient lives represented in the system that we have. You can see we're starting to be able to do some kind of top level analytics of what gender looks like and what race looks like, just as an example to you of how to split out our population. In our current model right now, just to sort of orient you to this diagram, on the green side here, these are ITHS funded organizations for Dataquest. These are data repositories that are federated throughout the WWAMI region that we currently have up and running. The orangish color here are the affiliated organizations that we also work with, but we don't directly fund. So we've got several of those. And then there are nationally aligned partner organizations out there through the Dartnet Institute, which is a network of networks across the country of practice-based research networks that encompasses about 3 million patient lives, depending on how you do the count. So we're aligned now with quite a decent network here of data in primary care practices. And then the boxes on the right represent these sort of potential future partners and existing partners that have more sophisticated systems. UW is an example of one. So the Amalga system is not semantically aligned necessarily, but might be doing partnerships with us in research, for example, down the road. We have other partners in the WAMI region, like in Montana, with their health information exchange, where they've got a sophisticated data sharing program going. They're not aligned yet, but they have plans to be potentially. So that orange area of boxes is really all those potential future areas. So I wanted you to see that as that's in the scope with us in terms of being able to interact with those. Just to give you a brief sense of the kinds of projects we've done so far in this Dataquest network. So we've been building this, and we've now, these are all bullet points of different projects that have either completed or are being done that interact with the data within our system so far. So if you kind of just look across them, you can see that these are people that are here local. These are people in different states. These are people even across the country that are using this data sharing network that we have now. The grants are teeny tiny, from KL2 award folks that are working on small piece of projects to the PCORI CDRN grants that are millions of dollars, where we're partnering with those. So we're really starting to have a nice growing portfolio of projects to work with. We're moving now, just to give you a sense, so that's where we began. And at the end of that pilot place, where we sat back and sort of looked at ourselves and said, okay, in the beginnings, we formed our team, we evaluated technical solutions of how are we really going to build this. We went with a vendor solution to put together these federated systems. Is this working? Do we have partnerships operating? And we came to that sense that, yeah, we've got these projects working, we want to move forward. And in those early phases, we really had to focus on building trust and really get these networks launched and off the ground, which Dataquest is a part of. These networks exist in and of themselves in their own data sharing efforts, in their own research bolstering efforts, and the data sharing electronic piece is just a piece of what those networks do. We really came to this sense that we do want to move forward with this. We want to figure out how to push this forward and where do we want to go from there. So in the current project at this point, we're really evaluating the utility of the data repositories. We're doing some active analyses on semantic alignment. How well are the data flowing between the practice sites? Can we easily combine them? Is it of good quality? Has the vendor done what we asked them to do? Have they accurately pulled data out of the EMR systems for as good or bad as it might be in those systems? We're doing active, in the meantime, participation in data sharing. So you can see we've got active research projects going on using the data. We're designing and deploying all the appropriate governance. Who knew I would figure out the ins and outs of a business associate agreement and a memorandum of understanding and data use agreement and data transfer agreements, and I get to know the Dean of Research and our Assistant Attorney General, but this has been the trials of the last few years. Getting all this governance in place is an ongoing process. We've also been doing a lot of, as of late, strategic planning, and it's really mirrored a lot of what the ITHS is doing and really setting a vision together with our stakeholders of where are we going with this, what is our vision, what are our goals, what are our objectives, how does this break down into actual targetable milestone-based projects in the next year, in the next coming years as we move through ITHS 2.0. So in the future, really what we see kind of coming down the pike in our sort of grand plan in the next coming years is growing our networks, launching new tools, expanding the kinds of research projects that use the system, and really aligning continually further with what's going on nationally. And so we're sort of on the bleeding edge along with our colleagues nationally, and we want to continue to be in that realm. Strategic planning, we're still iterating this. I'd say we're about 80 to 90% done with this, so take it with a grain of salt. This is not the final version, but I want to give you our vision statement, which we worked pretty hard on. The Dataquest is a powerful, evolving infrastructure now that harnesses the health data of patients served in diverse primary care settings, and that is easy to use and used by many to improve health. So there's a lot of pieces in there that we really felt were important. That this is an infrastructure, that we use health data. We didn't say EMR data. We didn't say just EMR data. So we have a vision of talking about all health data potentially could become a part of this. that we're talking about primary care settings. So this is a project that in general is centered in the primary care space, and that this really needs to be an easy to use system that lots of people use, and it needs to be targeted at health improvements. So that's, in a nutshell, what we're targeting. Again, this isn't meant for you to sort of read through, but to get a sense of the strategic planning we've been doing, where we've got 4 different missions defined against that vision statement. We've got 6 different goals down at the bottom here that really help us meet those missions. We've got now, these little boxes here are really all of our separate objectives. And then from that flows a set of projects that we're just starting to kind of hone and really craft. So please, again, with a grain of salt, these are not the finalized versions, but to give you a sense of our process right now and working with all our stakeholders to make sure we're on target. I've circled a couple here, model development and the Find It tool itself, as 2 things that I'm going to go over next. I want to talk to you guys about the current state of those things, and they really are big pieces that we're looking to the ITHS to be excited about and potentially even work on in this innovation space that ITHS is doing in terms of its own strategic planning. Okay, so the first one, really model development. Where are we going? So, that first diagram, we had this federated system. We had this vendor proprietary system where these federated clinical data repositories were placed behind the firewall at each of our clinical practice sites. There's big risk there. This is where it's single vendor dependent. It's a proprietary data model. We don't get to have access to it directly. We have to go through them to get it. We want to do that one better. We've been working with these colleagues who had called the Dartnet Institute, and there's a research group within that group that had one of the ERA ARC grants funded 3 years ago, and it was an $8 million project that was headed by Michael Kahn. It's a great informatics mind and really architected moving this kind of model forward into an open source space. And he scoped out within this safety net project developing really this electronic health network that collects and links data from multiple and different healthcare delivery settings. Meaning they had multiple partners. They took data, claims data and EHR data. They put it into an open source model. They developed an environmental space with software supporting it that took in data feeds. They defined a set data feed of what that spec needed to look like. If the data comes in this format, it can then be processed through a piece of software, and I'll talk to you a little bit about that, so that they could have semantically aligned nodes. Exactly what we were wanting. Wish they had done that 5 years before. Turns out they couldn't because they used a partnership that didn't even begin until 2007, but I'll talk about that in a sec. Okay, so what they decided to call this thing is Rosita, and they named all these things after the Muppets. I think I've got a picture, you can see her up there, okay? So it's kind of fun. They've got lots of cool Muppets, and she happens to be the bilingual one, so they thought that was really apropos for, you need to be able to translate these data back and forth. They also worked with, triad model of having grid nodes that were up and accessible with, again, governance that was in place that allowed for de-identified data sets to be shared at will between these different sites, and creating a portal across this safety net project. And they're right now at the completion of their 3-year cycle of putting this architecture in place. We've actually, well, don't let me jump ahead. Let me kind of orient you to it first. So it looks very similar to our model, right? You've got the EHR data up at the top, just like we did. They've actually got other sources, so they were getting feeds from Medicaid. This was a safety net-based project, so they were working with community health clinics that were doing a lot of safety net work. So they had claims data also pouring into their local data warehouse. They then were translating that with that tiny little black line. Let's not be convinced that that's an easy, tiny little black line, but they then translated the data into a set format that they pushed into what they used to call the black box that then became, I guess, a yellow box and called Rosita. And what that software does is it creates clear text PHI data of identifiers. It de-identifies the data into that limited data set, and then if the sites are agreeing to do it, it can also push it to a grid node that can then become available to the larger network, in a nutshell. So that's the idea, right? You've got each of these federated nodes now all out there. We don't have a node. We want to have a node so that we can participate more easily in what they've got going on out there. And so what they did is they looked at the Observational Medical Outcomes Partnership. Have any of you heard of that? OMOP? Okay, a little bit, not really. So this was a private public partnership that was developed between the NIH and pharma to come together to figure out a better way to store data that was complex. And one of the things they did is come out with a a structured ontology, essentially, that was able to be used by Dartmouth Institute and others now nationally around the country. They really finalized that in the late 2000s, and what Safety Net was able to do was take that, adapt it to the primary care health space, and modify it to also be able to include claims data. So that's the data model which we're built from in that Rosita environment. And again, OMOP is open source, very important. So it doesn't cost anybody anything to use it, and we can adapt it freely at will. It's not vendor dependent, it's not proprietary, it's not hidden. Okay, so what Rosita does really is it replaces those local codes with standardized codes. Okay, so for example, gender might be MF and 01. Right, so it gives it an actual standard set of codes across the systems. Lab codes, I can tell you, are a nightmare. They're always proprietary in every system, even though we have a laboratory ontology that's nationally available. No one uses it. So there's definitely significant ETL, significant extraction, translation, and loading of data into this system to make sure you're getting that right data. And then OMOP does a lot of mapping. It also, Rosita does a lot of mapping. She works hard at that. And then she spits out a bunch of exceptions to that, which there always are with every system. So as you're doing those loads, there's an iterative process you work through to map those codes. But each time you reload, it learns from that and stores those, so you don't have to redo that every single time as it goes. It replaces the direct identifiers with random ones, again, to do that de-identification process. It supports that clear text and encrypted record linkage so that you could backtrack if you needed to. So for example, if you do a research study and you're looking at de-identified data in the OMOP version, and then you wanted to go ahead and contact them and IRB approval was present, you could go back and re-identify who those patients were and go back to the practice sites who own it and ask them to contact those patients. They're also building a bunch of tools that provide data quality metrics, so we want those. We can't use them if we don't have this OMOP node, so that's another big advantage for us, is being able to look at the data quality a little more automatically. And it pushes the data sets to the grid nodes again voluntarily. I really don't know the answer if we're ready to do that yet. I think that's a governance question that we have to come to once we have an OMOP node up, of whether or not we're ready to sort of make that publicly, and it wouldn't be publicly, but it would be a little bit more accessible by these partners in the system. So take that model I just showed you. This is kind of what we're moving towards then. We take the current federated databases we have now and we create a centralized OMOP node for those partners that want to do that. So we have a lot of practices we work with who don't have a lot of IT capacity and or interest in creating their own OMOP node. And I think at the UW, through ITHS, we need to provide that service. And we need to say, we have an option for you to centralize and store that with us. It's not a requirement we have of our Dataquest participating partners, but it's a space we're trying to carve out at this point. The second group here, is an example of UW Amalga having its own OMOP node. So Peter and I have talked about governance complications of storing outside UW, non-UW owned data with UW owned data. So I think from an architectural standpoint, we'd have to have these in two separate spaces. So that's why I list those separately here. I realize I'm kind of missing one, which is nodes that our partners might be putting together, which maybe it's the boxes on the right, but really we do have some partners lining up already who want to be creating their own OMOP nodes. So I mentioned the Montana Health Information Exchange Group, for example. They're already targeting creating their own OMOP node, which would easily work with what we have. And then we've got Dartmouth Institute already existing, so they already have theirs deployed and out there, and potentially are working on expansion as well. Okay. So what we have done so far, thank you Justin, is configured the Rosita environment, which we do need to upgrade in January, by the way, to their newer version, but it did load pretty well. So data extraction specifications and initial data pulls are certainly completed at this point for getting this up and running, and we have data use agreements already in place now to manage that first set of initial extractions to create our first version of that. So that's pretty good. We're getting there. Next, we really need to convert our data to that required file format. We actually have that in the pipeline with Dartmouth Institute partnering with us on that, and we have a process in Rosita to produce the OMOP database that's coming. That piece of software is still working on its next version. within their development team, and they're hoping it'll be available in January. And then we also have a couple of grants in that I'll talk about that are going to really help push this forward as well if we get them. We have a couple of CDRNs. I can't help but publicly say we're going to find out on Tuesday, so we're all kind of waiting in anxious bated breath to see. Both of these grants are potentially $7 million total dollars each, so they're pretty big, and we have subcontract within each of these. That'll really help us move Dataquest forward if we get them. One of our other big issues is that we're having trouble, and this again is not specific to just Dataquest, this is across all of our data sharing systems, linking the researchers both locally and nationally to actually get to the data themselves. So that being the problem statement, one of the things we want to start doing concretely is figuring out how to do some good marketing to bridge that that missing component between the communities that we work with and the practices out there and the community of researchers, you know, which potentially have overlaps, and vice versa. We're very much about bidirectionality, and our communities and practices themselves have a lot of interests, and they need to have those interests and have their needs met by these research projects as well. So we're also challenged a little, you know, in a unique way in that sense compared to, I think, our institutional colleagues out there that are doing work where there really has to be a piece in it for the community practice partners to have some benefit coming at them for each of the research projects. So that bidirectionality is important. We need to, over time, really capture the research projects to evolve the content. I think that's what we're all talking about here, is we learn things as we go, we get better at figuring out where the holes are in the data, we get better at using the data. How can we organically capture that, share that, and not just have that be on yellow stickies with whoever did that analysis sitting on someone's monitor, or at least in the old days. So we need to help the community partners target semantic alignment gaps and increase research capacity as well with this. So rarely, if we go to them and we say, you know, we really wanted to do this tobacco cessation project with you, but you're not tracking your smoking information on your patients in a codified way, so we can't. Oh, wait, we can change and we can do that. You know, so our practice partners are interested in improving the way they code data for research too, and we try to keep that in mind. So in the immediate term, we're trying to figure out what views of data would be helpful to really attract and inform a potential researcher as we target this down. And we've been developing a website, because what do you do when you have a problem with marketing? You put it on the web, right? So we've got a website brewing, and we've got a tool within that website, you know, and I know this is really small for you guys to see, but I meant to just sort of float through these with you before I get into some specifics of what Find It actually does. So really what we want to do is discover the breadth and depth of the data across the network. Here's the problem I'm faced with. When anyone comes to me and says, you know, I'm interested in Dataquest, what data do you have? I sit there and go, So I figured a few years ago, we started carving out within the ITHS work we were doing a little tiny project that's kind of grown into this idea of let's build a Find It tool that is going to answer that, where we can say, I don't have to say I can say, go look at Find It and start exploring what data we have in our system. I named this was my brilliant thought of 2011, the Federated Information Dictionary tool. I haven't had any more since then. So I'm going to hold it to just that one and explore, you know, really we want to explore the data that's shared across the network. We want to explore the research priorities of the partners through this tool. It's got 3 different features in our 1.0 version. So you can browse by data types themselves. So the typical way we kind of think about those of us who work deep in EMR data, you know, there's patient demographics, there's medications, findings, procedures, et cetera. Down this list, what you can do, well, I'll show you kind of what each of these features do. First, let me just kind of go down each column. You can also browse by diagnosis, which is a really just high demand question that a lot of folks ask us all the time. Do you have diabetics, and how do you track that? And then the typical traditional data dictionary. What are the data arenas you have? What are the columns, and what do they mean? Just from a basic data dictionary standpoint. Okay, so if you look at each of these, what we do is we, on the left, browse by data type. You can pull down patient demographics. When you click on this link, you get gender, race, ethnicity, language, for example. You click on one of those, you can see the one we've picked as ethnicity. You can see a breakdown by ages, And this is just how we've decided to kind of break the data down. We're not trying to do really refined cohorts. Again, you're not meant to read these numbers as sort of test data that's not ready to be released publicly yet, but you can get a sense, Hispanic, non-Hispanic, how many patients' lives are tracked with that variable and what percentage of the total, so getting some sense of denominator and how many out of your population is that. The middle column is really meant to be a searchable tool where you can put in an ICD-9 code of any code you want and get some kind of account breakdown where we give you some sense of how many clinics and how many sites, not how many clinics at how many sites, because again, anonymity, but giving you some sense so the researcher can kind of get a sense of, oh, you've got a bunch of kids with autism, but oh shoot, there are 10 different sites and the number you need is the total number I need, and I can't work with 10 sites, I need one site that's going to have that many. And then the data dictionary, again, you can pick a content area, get a list of what are the major variables that we tend to have, and get some English description of what's in there. The status of this project is really moving towards getting 1.0 launched. So we've got the programming resources that are already in place. We've got a user design test that we actually conducted with a great research assistant of mine recently to iterate the design a bit. So we've got the 1.0 specification now finalized with Hussein, who's here, who's working this quite a bit as my current research assistant. We really want to figure out how to launch that the best and don't have a set plan with that, but we're iterating it. Let's see. And then the 2.0 specification is where I'm really excited actually to go forward with some more complicated ideas and scoping that out and figuring out timeline. And so some of the things that we're looking at is how can we expand this to the other CTSAs. We've got some of our Dataquest partners in Dartmouth Institute are at other CTSAs and have a semantically aligned network that mirrors ours. So can we pull their data into Find It as well to show that you could easily do data mining projects on these other networks too? Can we target organic capture over time, again, as we've been talking about, as we find these things, how can we get this input into the Find It data itself so it lives and breathes there and continues to evolve? And how can we continue to build out functionality to do patient cohort finding? Would that segue with, for example, the work we're doing with I2B2 here, or other tools, PopMedNet or other potentials down the road. This is our team. This is who's working on this at this point in informatics, and then we do a ton of work with these folks in these two different networks. Laura May, thanks for coming.